Let's talk about how digestion occurs. Digestion begins in the mouth. Our food is chewed and then continues down our esophagus as a bolus of chyme, and that moves into the stomach. The chyme then moves into the duodenum, and we get our digestive hormones that stimulate our pancreas to mix in some of the enzymes it needs to digest our food. So, how does nausea occur? Well, enterochromaffin cells in the GI tract detect our nausea-producing stimuli. It's going to activate those specific target sites, which is going to trigger their emetic receptors. Emetic agents in the blood also can directly stimulate the chemoreceptor trigger zone, or CTZ, and that communicates with the vomiting center in our brain to induce emesis. So the first class of medication that we want to look as far as antiemetics, and anti meaning without, and emetic meaning vomiting. This first one is ondansetron. Ondansetron is a pretty popular drug. You may have heard it referred to as Zofran. And what it's going to do is it is going to act like a serotonin on the brain that is going to prevent that CTZ effect. Okay, so these medications are going to have a quick onset. They also are going to help with regulating GI functioning because of their serotonergic transmission. It is to treat nausea if it's chemotherapy, radiation, surgery. We have a plethora of ways to use, or people that get on ondansetron. You probably, or one of your family members, have received a prescription for ondansetron as well, because we like it, because it's a newer generation drug and it doesn't always cause sleepiness. People that should not be using this, of course, anytime we have someone who has a hypersensitivity to a medication or to one of its ingredients, we don't want them to use that. If they have liver impairment, we want to be very careful with giving it. Remember, most meds are going to be metabolized through our liver, and so we don't want to get a buildup of this medication within them. Now, they also have a box warning for serotonin syndrome, so if we have someone who's taken like an SSRI or SNRI or a tricyclic antidepressant, we want to use those cautiously. Kind of some of the common side effects that we're going to see are going to be things like headache, dizziness, constipation, and diarrhea. Less common, you might see some redness or pruritus, especially if we've given it during via injection. Again, I said most people don't get drowsy, but you may see someone who gets drowsy taking this medication. Adverse effects, we want to look for arrhythmias. We want to let our clients know what the purpose is of this medication, how to take it. We have to let them know any potential side effects that could develop for them. Let them know they need to call their provider if they get a severe headache, dizziness, or palpitations. If they are pregnant or planning on becoming pregnant, we want them to let their provider know before they start taking this medication. The next class of medication is the anticholinergics. Anticholinergic, and when we're talking about a cholinergic, cholinergics is wet, so anticholinergics, these are going to dry you up. The medication prototype that we have for this one is scopolamine. Okay, so what happens is the muscarinic receptors are blocked using this medication. It's the M1 specifically receptor, if you're interested in knowing that. Scopolamine's action of onset is 4 hours and the peak is 24 hours. We use it for post-op nausea, nausea caused by motion sickness. So think about if you've been on maybe an airplane or you've been on a cruise, you'll see people walking around. They've got looks like a little small circular Band-Aid behind their ear. They have a scopolamine patch on to help with their motion sickness. Contraindications, of course, are allergies to the medications. If we have someone with psychosis or history of seizures, we want to monitor that. Remember, these are going to dry you up, so they could cause some blurred vision, dilated pupils, can cause dry mouth, and decreased GI motility. There are not really any adverse side effects we worry about. If they do start to have some of these uncomfortable symptoms, all we have to do is remove the patch, and usually those resolve. So again, we want to go over the purpose of the medication here for them. Talk to them about what we can do to address the dry mouth or constipation that may occur. So things like suck on hard candies, make sure you're drinking plenty of fluids. We want them to put the patch on the night before surgery if they're having it on for surgery, or at least 4 hours before anything that would cause them to have motion sickness. We don't want them to cut the patches. That could cause some damage to it. The next class is dopamine receptor antagonist, and our prototype for this is metoclopramide. This acts as an antagonist to the dopamine receptors in the CTZ. It's going to increase the tone of the lower esophageal sphincter, which will help to decrease our acid reflux. It's going to increase peristalsis in the stomach and the intestines, but it's also going to relax that pyloric sphincter. It's going to decrease the nerve sensitivity in the GI tract that goes to the CTZ, so it's going to block that vomiting reflex. Metoclopramide is quickly absorbed in the GI tract. Its peak, meaning where it's at its highest level, is about 1 to 2 hours after they take it orally. If we're going IV administration, its peak concentration, again, is about a 1 to 2 hour duration. Now, it is approved by the FDA for treatment of nausea and vomiting in people that have like GERD or diabetic gastroparesis, or we can also give it parenteral relief for chemo-induced nausea and vomiting. If we have someone with GI bleeding, a GI obstruction, GI perforation, we do not want them to take this medication. We don't want people with Parkinson's to use this. We don't want to give it to those who are comatose, those who have seizures, those with pheochromocytoma. If we have someone who already has a history of depression, it can cause them to go into a major depression. This does have a drug-to-drug interaction with aspirin, bupropion, antipsychotics, antidepressants. Side effects, I don't see these a lot with people that take metoclopramide. Drowsiness, extrapyramidal reactions, and restlessness. With long-term use, we could see some extrapyramidal manifestations. Again, tell them all about the medication, how to take it. If they begin to have restlessness, anxiety, spasms on their face, or lick smacking, writhing motion, and involuntary movements, those are signs of extrapyramidal manifestations, and we want them to report those immediately. The next is antihistamines. The prototype that we use for this is promethazine or Phenergan. We can also use diphenhydramine or Benadryl to help with nausea and vomiting as well. So the antihistamine is going to block the H1 receptors that controls the vomiting center in the brain. So promethazine is supposed to reduce nausea caused by motion sickness, chemotherapy, post-op. What we don't like about it is it does cause sedation in a lot of people. It also has some anticholinergic effects. Again, think about the antihistamines, they dry you up. So that does happen. This used to be the gold star, but when we came out with ondansetron, we found something better that worked better and didn't have as many side effects. Contraindications would be, again, the known hypersensitivity, people with angle closure glaucoma, Breastfeeding, those that are breastfeeding, we don't want them to be taking this as well. We want to use it cautiously in those that are pregnant and in our older adults, in people that have hyperthyroidism or cardiovascular disease, liver disease. We don't want to use it on children that are under 2 years of age. We don't want to use it in people with a history of seizures. It can have some drug-drug interactions. So, for example, if they're taking a central nervous system depressant, it might increase the sedative effect. If they're taking an MAOI, it might increase the anticholinergic effect. Side effects, as I mentioned earlier, sedation, drowsiness, dizziness, blurred vision. And again, it has those anticholinergic effects, so they might have some dry mouth, constipation, urinary retention. As far as the adverse side effects, they might have anaphylaxis to this medication. It may cause them to have seizures. Diphenhydramine, we have to be careful that they are not taking up too much because it can be toxic to them. And remember, diphenhydramine can be in a lot of different things. Diphenhydramine can be in things like your NyQuil-Z. It can be in a lot of your cold, or it is in a lot of your cold medicines. So we want to talk to our clients about the medication. If they begin to experience delirium, seizures, tachycardia, make sure they notify their provider immediately. We're going to talk about gastroesophageal reflux, or GERD. If our lower esophageal sphincter does not contract properly, it may cause symptoms of GERD. Maybe it's because of a decreased tone, or something for some reason causes it to lose its ability to contract. That results in gastric contents being allowed to flow back into the esophagus, including that gastric acid. Now, the pH of your gastric acid is about 1.5 to 3.5. And remember, normal, we want right there about 7. So it's pretty acidic. Because of its low pH, it can be very damaging to the mucosal layers of the esophagus, so it can cause some erosions there. Some of the risk factors that can contribute to GERD: if you have a hiatal hernia, if you have any defects in the protective lining of your esophagus, some people might have delayed peristalsis. If there's anything that is increasing our intra-abdominal pressure, so like pregnancy, people with a high BMI or a BMI over 30, it pushes on that diaphragm and it can push that food back, or push that chyme back up through your esophagus. So clinical manifestations: GERD can cause both esophageal and extraesophageal manifestations. So things like esophageal manifestations, we think of heartburn and regurgitation. So kind of a little bit of vomit comes back up in your mouth, or you feel like a little bit of vomit comes up in your mouth, or you bend over and you have a little bit of your stomach contents that goes up into your mouth. Some unexpected would be like a chronic cough. So you might see someone who's starting to have a bad cough, and it's not really an allergy or inflammation of the lungs, but it's because of that acid reflux. They might start to lose some of the enamel on their teeth. They might get laryngitis, dysphonia, hoarseness. They might have sore throat or chest pain. So some complications: if we do not treat GERD, we can have things like erosive esophagitis. So maybe they have difficulty swallowing. It can cause holes, for lack of a better word, ulcerations in their esophagus. They might develop something called Barrett's esophagus, which is a precursor to esophageal cancer. And then they might also aspirate a lot, and so they might get maybe aspiration pneumonia as a result. GERD can also lead to peptic ulcer disease. It is diagnosed as peptic ulcer disease when there is an ulcer confirmed. They usually can visualize this with endoscopy. The ulcer presented in peptic ulcer disease results from some type of imbalance of the gastric acid in your gastrointestinal tract. Now, the risk factor, main thing is going to be that H. pylori bacteria. We used to think, oh, this is due to our diet, to stress, and all of those other things, but a lot of times the big reason we get peptic ulcer disease is because of the pylori bacteria. H. pylori bacteria. Some other things, increased use of NSAIDs. NSAIDs are very rough on our stomachs. Genetics, long-term use of corticosteroids, biphosphonates, which is to help strengthen your bones. If we use a lot of potassium chloride, even some chemotherapy agents. Other people that are at risk for peptic ulcer disease are those that have high tobacco or alcohol use. And then also some people have neuroendocrine tumors that are going to secrete that gastrin that's going to cause this. So what we want to do is look at these factors and say, okay, what can we prevent? So things like limited or no use of NSAIDs, limited or no use of alcohol, and smoking. So the complications that we have to worry about is they'll have bleeding in the upper gastrointestinal tract. They might also have a narrowing of their gastric outlet. This is from the scar tissue building up, and it can cause an obstruction for them. They might have a perforation of the stomach or duodenum. Again, that's going to allow the contents of the stomach or duodenum to spill out into their peritoneum. That can lead to peritonitis. The ulcer may penetrate out to another organ, or it can cause gastric cancer. So some things that we want to watch for people with peptic ulcer disease is hematemesis, so blood in their vomit. Another thing is coffee ground emesis, so if they throw up and it looks like the used coffee grounds, that's probably because there's blood somewhere in their GI system. Black tarry stool, again, same thing. It's that dried blood that's coming out. A lot of times they'll have severe abdominal pain, and some of them will have intentional weight loss. Some of them may have weight gain because when they eat, it takes away the pain. Antacids, we can buy these over the counter. They're very commonly used. We use them before we go to see our doctor and get put on something else. They're made of calcium, aluminum, and magnesium salts, so we have to think about this with any medications. So the aluminum hydrochloride and the water neutralizes our acid, so that's going to prevent that activity of pepsins. Now, it's not going to reduce the gastric acid. It is going to prevent that pepsin from acting. Antacids can also heal ulcers as well. Effects on the body. When we take antacids, we should have decreased discomfort. However, remember that if we are taking too many antacids, we are at risk of developing hypercalcemia because those antacids some of them contain calcium. Why would we take it? GI indications, dyspepsia, heartburn, GERD, and peptic ulcer disease. And if we're allergic to any of the components in an antacid, we don't want to be taking that. We don't want, or we want to monitor our clients with renal disease because some of the antacids might have a lot of potassium, magnesium, or aluminum in there. So their kidney specialist will tell them exactly which ones are appropriate for them to take. If we have a sodium sensitive condition like congestive heart failure, we really want to use caution with using those as well. H2RAs, this is your cimetidine, ranitidine, famotidine. Some of these can be purchased over the counter. They are to prevent that gastric acid release. So they are not allowing the acid to be released. It's going to block those acid producers. It helps if we're trying to get a peptic ulcer healed, and it's also going to prevent new ulcers from forming. So if we have a duodenal ulcer, if we have a lot of heartburn, dyspepsia, GERD, peptic ulcer disease, we can use this. It also helps with prevention of stress ulcers. We want to look at some of these might have alcohol in them, so we want to make sure that if we have someone who cannot take alcohol for whatever reason, that they're not using these. Some of these are going to have aspartame in them, so we want to make sure that we are looking at that. If you're over 50, if you have kidney dysfunction, liver dysfunction, if you're pregnant or lactating, we want to use those with caution. Usually these H2RAs are generally well tolerated. Some of the common side effects we might see are things like drowsiness, constipation, diarrhea, headaches, abdominal pain, fatigue. We don't really see a lot of adverse effects, but if we use them for years and years and years, or if we're using really high doses, we might see things like a granulocytosis. They might develop aplastic anemia. Especially with cimetidine, they might get some sexual dysfunction. So we want to make sure that when we're educating them, we let them know, hey, these are just for short-term use. We really don't want you taking them more than 2 weeks. We want you to take it either with your first meal of the day or at bedtime. And of course, we want them to report the things that would signify either peritonitis or blood in their GI system. So those things like black tarry stools, fever, rash, difficulty swallowing, if they're vomiting blood, those types of things. We want them to take the full course as prescribed. And of course, we do not want them smoking while they are taking these meds. Proton pump inhibitors. So we have these little proton pumps in our stomach, and it helps, it creates that gastric acid. So proton pump inhibitors, it's going to inhibit that gastric acid from producing. So the effects, we're going to have less acid production on our body. So if I have something like erosive esophagitis from having GERD, if I have a peptic ulcer, I can take this also. If I want to prevent a peptic ulcer, I can take this. We want to use caution in those that have liver impairments, those who are pregnant or lactating, or if they're taking a medication that can interact with the PPI. So phenytoin, warfarin, diazepam, you'll find those medications are frequent interactors with other medications. They don't play well with everybody else. Some of the side effects we might see, they might have some dizziness or headaches. They might have abdominal pain. Some of these can cause nausea or constipation. Again, these are intended for short-term use. The longer we use them, the greater risk of adverse effects. And I kind of laugh when I say this because a lot of people are on them for several years. Their provider's aware of it. So just know that you will see people who have been on PPIs for years and years. So some of the adverse effects we'll see is osteoporosis. That's a huge one because they're not able to absorb the calcium. They might have some vitamin and mineral deficiencies. Iron, magnesium, and calcium could cause a Clostridium difficile infection. And then probably the big thing is when they're coming off of this, especially if they've been taking it long term, they might start to get a rebound acid secretion. So what we would want them to do is maybe instead of taking it every day, have them take it every other day for a few weeks or a couple of months, and then maybe go down to every third day. Just kind of taper off gradually there. So we want to explain the purpose of this medication. We want them to take it 30 minutes before eating the first meal of the day. Again, it's going to stop that acid from being produced, and that's what we want. Let them know the side effects. Remind them again, report diarrhea, black tarry stools, abdominal pain. We may need to also monitor their B12 level. Other medications, we have what's called a mucosal protectant sulforaphate, or what you may hear carafate. What this does is it binds around the stomach lining and it creates a barrier so that when the food gets in the body, that it's not going to touch those sore areas. Okay. We want them to increase their fiber and fluid intake. It can interact with some drugs and cause a decreased effect on some of our antibiotics, warfarin, phenytoin, digoxin. If we take more antacids, it can increase the effect of it as well. Next is inflammatory bowel disease, and there's two that we're going to look at here. Crohn's disease and ulcerative colitis, and these are very closely attached to each other. Crohn's disease, this is a chronic, remember it's chronic, inflammatory bowel disease. So it can affect any part of the GI tract. Most commonly, though, we're going to see it in the small intestine. So they get this disease, it leads to inflammation, ulceration, thickens those intestine walls. So these people get abdominal pain, they have frequent diarrhea, fatigue, weight loss. Ulcerative colitis is a chronic inflammatory bowel disease that affects usually just the colon and the rectum. It's going to cause inflammation and ulceration in the inner lining of the large intestines. So that's going to cause abdominal pain, fatigue, weight loss, diarrhea. They may even pass some blood or mucus with their diarrheas. So how is this going to affect the client? Well, in Crohn's disease, remember they have inflammation, or both of them they have inflammation, but they're going to have usually right lower quadrant pain. It's an inflammation, so they'll have diarrhea, and sometimes they may even run a low-grade fever. If they have inflammation in the jejunum, they'll have diarrhea, they'll have malabsorption, steatorrhea. They might begin to have deficiencies in their nutritional and electrolytes as well. Inflammation in the colon and perianal area. They might have some anorectal pain, some incontinence, hemorrhoids, and they can even start to develop fistulas within the stomach, small intestines, or in their rectovaginal area. They go through periods of relapse and remission. So they might have like flare-ups or spells of this happening. Now, ulcerative colitis, the main manifestation that we see with this is bloody diarrhea. They might have some bowel urgency. They might have some abdominal pain, malaise, weight loss, fever. Again, as with the Crohn's disease, they have periods of relapse and remission. So one of the medications that we use a lot is an immunomodulator, methotrexate. Methotrexate is a steroid, okay? These are used to reduce that inappropriate immune response. So it's going to suppress the inflammation. If we can suppress the inflammation, maybe we can prevent some damage to their intestinal line. Now, methotrexate is a disease-modifying anti-rheumatic drug, so it works right there where it needs to work on the correct enzyme. The effect on the body is it is going to decrease the body's inflammatory response. So our goals here would be that they have less abdominal pain, less bleeding, and that they're not having any other manifestations associated with intestinal damage. We can use it sometimes for irritable bowel disease. That's kind of an off-label use. If we have mild Crohn's, it helps to maintain the remission. They're usually given it with another medication like a corticosteroid until they get to the level of disease that they want, level of remission. For moderate or severe, we're giving them to them with anti-TNF medications. Contraindications, again, if I have an active infection, I don't want to take these, or if I have some type of known cancer, if I'm breastfeeding. Side effects, the main side effects we're going to see are going to be things like nausea, vomiting, loss of appetite. This may also cause them to have some ulcerations to the mucous membranes. It can cause some arthralgia, some alopecia, and some rashes. Some of the common adverse reactions we see are if somebody's going to have severe nausea and vomiting, anorexia. They might start having mouth ulcers, liver toxicity, fevers. It can cause bone marrow suppression. So we want to let them know what the purpose of the medication is, how they should take it, and let them know if they are getting any unmanageable nausea and vomiting to please let their provider know. Because it does have steroid effects, we want to make sure that they are trying to remain infection-free. So we want to teach them infection prevention activities. We want them to use birth control while they're taking immunomodulators. Laxatives is next. The one that we're going to specifically be talking about is magnesium hydroxide, or what we call milk of magnesia, or MOM. You may see it abbreviated as just MOM. It is going to draw water into the intestinal tract. It is a saline, what we call a saline laxative. And if we have constipation, we can use it. It also works with some indigestion. Those that have kidney disease, we want to use it cautiously. It can cause diarrhea, stomach cramps, bloating, nausea and vomiting. And while I say these are side effects, this is kind of what we want. That is indicative of our GI system starting to function and trying to get rid of the feces that is built up. Some of the adverse effects, it is magnesium, so that person might have hypermagnesemia. So if our kidneys aren't working and can't get rid of the magnesium that we have in our body, we probably don't want to take this medication. It's only for short-term use. We do not want to use it if our constipation gets worse or if it does not improve. An osmotic laxative is polyethylene glycol, or what we call Miralax, or the Go Lightly. This causes that water to be retained in our intestines instead of going out to the body, so that stool is able to pass. That increased volume helps to stimulate someone to have a bowel movement. We use it for constipation. We use it for prevention of constipation. The Go Lightly is what we use for a bowel prep if we have someone undergoing a colonoscopy. Contraindications, times I would not want to use it, is if I already have someone with a bowel obstruction or appendicitis. People with appendicitis, I don't want to do anything to cause any additional pressure in their lower abdomen, because that could cause the appendix to rupture. Some of the stuff that they will probably see is bloating, gas, nausea, and of course the stomach cramps. Adverse reactions would be diarrhea or hives. So the Miralax comes in a powder, and you usually mix it with a full glass of, say, water or juice. People mix it with all different things. You can mix it and then drink it. We want at least 8 ounces of water with this. It might take them a few days to get a bowel movement. And the big thing that I always teach people is make sure that you're increasing your intake of liquids during this time, because you can get dehydrated very easily, and if we're not drinking enough fluids with it, it's just going to do the opposite of what we want. It's going to make you constipated. Lactulose is another osmotic laxative that we talk about. You will see a lot of liver people that take this, people that have difficulty with liver, so always remember L for lactulose, L for liver. What lactulose does is it grabs onto the ammonia. So if I have someone in liver failure, they have a lot of ammonia throughout their body. So we'll give them lactulose to grab a hold of that ammonia and get it out of their body. It is going to draw water into the colon. It's going to decrease that ammonia level. So let's say I have someone maybe who's in late stage liver disease, and they have high levels of ammonia, and ammonia is a sedative to them, or someone with chronic constipation, I would probably want to give them this. If we have someone with an intestinal obstruction, absolutely we don't want to give it to them. One of the side effects, which is basically what shows that it's working, is they have diarrhea, and this is why people with liver disease do not to take lactulose, because they are always in the bathroom. Okay, but that's what we want. We're trying to get rid of some of that ammonia that is in their body. They can have, again, nausea, stomach cramping, vomiting. Anytime you give any kind of laxative, you'll see that they have the potential for getting nausea, stomach cramping, vomiting. One of the things it can do is it can dehydrate them if they're not drinking appropriate amounts of fluid. It can also cause electrolyte imbalances, because a lot of these electrolytes are going to leave through our GI system. Now, it may take a couple of days for us to see any results on this, and the big thing is just stay hydrated. We want them to stay hydrated, or else that can make their problems even worse. The next type is bulk forming, the Sililium. Metamucil is the common one we think about this. So what this is it creates that bulky stool. So it's going to absorb that liquid in our intestines. It's going to swell up, and it's going to make that stool a little bit softer so it's easier to pass. We can use this for both constipation and diarrhea. It can help to pass those that are constipated, and it will create a bulkiness for those that have diarrhea. We know that this is like a fiber, and we know that if we have high fiber, it's good for lowering our cholesterol, helps to control our blood sugar, and it helps us to feel full for a little bit longer. We wouldn't want to use this if we have difficulty swallowing or if we have intestinal blockage. Again, we want them to stay hydrated. We can mix it with water or juice, or we do mix it with water or juice, stir it up really good, and then let them take it. The longer it sits there, the thicker it's going to get. And again, it could take up to 3 days to produce a bowel movement. Surfactants. Docusate sodium is the one that we're looking at here. It has that surfactant that lowers the surface tension of the stool. So what it does is it mixes fats and water there into your fecal matter there. It's going to help with relieving constipation, so it's going to help prevent straining. So if we have someone maybe who has cardiac disease and shouldn't be straining because it can cause a vagal response, we want to make sure that they are on something like docusate sodium. People that are on opioids, we know opioids are very constipating, so they might take docusate sodium as well. Again, intestinal obstruction, we don't want those people taking it. Appendicitis symptoms, if they're impacted, that's just going to make our problems worse. They may have some stomach cramps. It may cause some dehydration on them as well. We don't, as a rule, want them using it for more than 7 days, because you can get addicted to this. It may take a while to produce a bowel movement, up to 3 days. Now, I'll tell you, I watched a TikTok where a pharmacist took one of these docusate sodium and he cut it open, and inside of it, it was just soapy water. So if you want to try that, let me know how it goes. And in the opposite end of the spectrum, we want to talk about an anti-diarrheal, which is loperamide, or what we call Imodium over the counter. It's going to slow the movement of your gut. So if I have someone who's having a lot of bowel movements, they're having diarrhea, and we're talking about 8 to more bowel movements per day, I don't want them losing that much stool, because with that is going a lot of their fluid, and they're going to get dehydrated very quick. They're also going to um, lose a lot of their electrolytes as well. So this is something that we could give them to help to slow down the motility. That's what it does. It slows the motility of their GI system. Now, if you already have black tarry stools, a high fever, if you have C. diff, we want that stuff out of you, okay? So go ahead and let that stuff go. The big side effect that I always say, I'm very hesitant to encourage my clients to use this, is constipation. In my practice, it seems that we have someone who has diarrhea, they take a few doses of something like Imodium, and all of a sudden they're constipated. So just be very careful with that. We don't want them to exceed the recommended dose, and of course drink plenty of fluids to replenish all of those that they've lost with the diarrhea. Now, there is a prescription antidiarrheal, and what it does is it's an opioid receptor that we use to treat diarrhea. Because of the opioid epidemic, there's been people who try to self-treat opioid withdrawal symptoms, or they use it to get a high. So we do monitor this. This is one of the controlled substances, Lamotil.